Thanks, everybody, for joining. We're going to get started here in just a minute. While you're waiting, please take a look at these questions and scroll through. There are actually 3, so you need to scroll down. Thanks so much. Okay, I think we'll get started. Thanks again for joining today, our webinar on antiretroviral management of HIV with data from CROI 2024. I'm Judith Currier from the University of California in Los Angeles, and I'm joined today by Dr. Eric Daar, who's a professor of medicine and chief of the HIV division at Harbor-UCLA Medical Center. Before I turn it over to Dr. Daar, just a few housekeeping messages. Want to just highlight our content on the web board for IAS-USA, and the disclosures of our members are on this slide. Also, financial relationships with companies in the last 2 years are on this slide. The CME information is 1.25 AMA Category 1 credits. We also have ABIM mock credits in addition to nursing and pharmacy credits for the activity today. The contributors are shown on this slide. And then for this activity, we are going to have some polling questions during the presentation. We'd love for people to submit questions using the Q&A. Don't put your questions in the chat, but if you forget, we'll move them over. And we'll try to answer as many as we can at the end of the presentation in the time allotted. So now I'm going to turn it over to Dr. Daar, who's got a really terrific presentation about all the new antiretroviral data from CROI 2024. Dr. Daar, take it away.
Thank you, Judy. It's really a pleasure to be here. Thank you all for joining, and hopefully everybody can see my slides now.
Yes.
Excellent. So this is a great opportunity. Hold on. Having trouble advancing them. Here we go. Okay, great opportunity to share with all of you some of the amazing data that was presented at this year's 2024 CROI. Always one of the highlights of the year from a clinical and basic science research perspective. And there was particularly a lot clinically that I think was impactful on what we do in practice. And in selecting topics for discussion, I focused on what I think will be obvious choices from a clinical perspective for therapy, but also some things that I think are closely aligned with what we do therapeutically that might impact our practices. So at the completion of the activity, we'll list the most recent findings from clinical studies in antiretroviral management, describe the implications of the data for state-of-the-art treatment strategies, and integrate some of this into clinical practice. I'm going to go ahead and start with a poll question for all of you. Which of the following do you think would represent the greatest advance in antiretroviral therapy for the largest number of your patients? Starting long-acting injectable therapy every 8 weeks in viremic patients, once-weekly oral switch options, long-acting injectable switch options administered every 6 months, or none of the above. I believe once-daily oral therapy will likely remain preferred for most of my patients, or finally something else. Go ahead and vote. Okay, great. So most people picked long-acting injectable switch option administered every 6 months. Well, some of what we're going to talk about today are options that are on the horizon that might move us in each of these directions. And that's why it's nice to hear what people think might be most impactful. So we have some pre-test questions that we'll then come back to after the presentation. The first one is, which of the following is true regarding data from the CARES study? Virologic failure was more common in those with resistance identified by proviral testing. There was no increased risk of virologic failure in those with subtype A1 virus. Viral suppression was more common in those on long-acting cabrolpivirine than continued oral therapy, or injection site reactions were common and resulted in several participants discontinuing treatment. Go ahead and vote. We won't be showing the answers, I don't believe, at this point, but we will at the end. We have a lot of people who've been kind enough to join us today, so we'll give you a few minutes, or seconds anyway. Oh, I guess we are showing the answers. About half said viral suppression was more common in those on long-acting cabrolpivirine than continued oral therapy. That was the most common choice. Which is true about the Latitude study? This is long-acting therapy to improve treatment success in daily life. A, it was not a randomized clinical study. B, all participants had virologic suppression at the time they started long-acting cabrolpivirine. C, those given long-acting cabrolpivirine had lower rates of virologic and treatment-related failure. Or D, in the long-acting cabrolpivirine group, on-time dosing only occurred 70% of the time. Go ahead and vote. So the most common 2/3 of you is those given long-acting cabrolpivirine had lower rates of virologic failure. Okay, excellent. Well, let's go ahead and talk about this and other studies. So I'm going to start with the CARES study, which was one of our questions. This was long-acting cabotegravir-rilpivirine switch in Africa. As you know, long-acting cabotegravir-rilpivirine has been widely available in parts of the developed world, including the United States. And it's available and FDA approved for both every 4-week and every 8-week dosing. The registrational trials that supported the approval of this regimen were not done in resource-limited settings, and were done in a relatively, stable, suppressed, very reliable patient population who were really good at taking pills. And the goal was to really see whether this kind of a regimen would be effective. The CARE study tried to look at this in the context of a resource-limited setting and looked at more of a public health approach, something that would be doable in such a setting with less frequent monitoring, since viral load testing and things like that may not be as readily available in those settings. So it enrolled a typical population of people who were adults on stable oral therapy. Most of them were on a dolutegravir and an NRTI-based regimen. They were virologically suppressed for at least 4 to 12 months prior to screening. Importantly, had no history of treatment failure and no HBV infection, which was defined as anybody having had previous HBV exposure, meaning core antibody positive. So that was the population. And they were then randomly assigned 1-to-1 to standard of care, oral continued therapy, or they had an optional oral lead-in with cabrolpivirine for 4 weeks, followed by the injectable every 8 weeks. And you could see that monitoring was done somewhat less frequently, with viral load measurements done every 24 weeks. So considerably less than what would happen traditionally in clinical practice. Now, they didn't look at resistance testing at baseline, but they did have stored peripheral blood bonded nuclear cells, since these people were all suppressed, that they did proviral DNA sequencing on in a batched way, and then looked at that data retrospectively. So these were the 3 areas in which recruitment came. This is the consort figure, and the main reason I show this is that you can see that a substantial number of the people were excluded because they had anti-hepatitis B core positivity. A small subset of those actually were surface antigen positive. And this is an area and topic of discussion in that when you take somebody who's stably suppressed, who doesn't have evidence of chronic hepatitis B infection based on antigen or DNA, is it a problem to take them off a potent high barrier hep B drug like tenofovir, for example? How much risk are they at reactivation? A lot of the pivotal trials, including this one, chose to be conservative and exclude these people. Importantly, noting that it resulted in a considerable number of people not being able to access this treatment. And we'll come back to that in a moment. Very high retention rate. These are the baseline characteristics. No big surprises here. Somewhat higher female than male proportion, and that's not surprising based on where this was conducted. About 20% were obese with a BMI of over 30. You can see that the majority, 92% of people, were on an INSTI-based regimen at screening. Now remember that these are all people who had never experienced virologic failure, but some of them may have switched therapy when stably suppressed. And then what's listed down here at the bottom was the data that was derived retrospectively from the stored PBMCs. And there are a few interesting things to comment on. One of them was that more than half had subtype A1. Those of you who have used and looked carefully at the package insert and some of the early data are aware that it talks about people who have subtype A1 or A6 being at somewhat higher risk for virologic failure. And mostly this is designated in the package insert as A1/A6. A6 is the subtype predominantly found in Russia, A1 in other parts of Europe. It doesn't really distinguish that data between those two subtypes. So interestingly, more than half of these people had subtype A1. The other thing that's interesting to note, based on this archived assay of proviral DNA sequencing, that about up to 15% of people had evidence of resistance in their PBMCs to rilpivirine or cabotegravir. Again, not known at the beginning. So here's the data on the response rate, and it's not. It's very promising to see that the results were exactly what you'd expect based on the registrational trials done in resourced countries, with 97% of people maintaining virologic suppression, and very few people experiencing viral rebound, and clearly met the non-inferiority criteria for this study. In fact, there were only 2 people with viral failure in the long-acting cabotegravir rilpivirine, none in the standard of care arm. And this is confirmed virologic failure repeatedly above 200 copies per mil. One of them was subtype A1 with emergent resistance to cab and rilpivirine, and another one died before confirmed, but was known to be subtype D, who also was found to have resistance to cabotegravir and rilpivirine. Now remember, more than half of these people had subtype A1, and 15% had evidence of resistance based on the proviral DNA. Despite this, the virologic response rates were outstanding and as good as anyone would have predicted in any setting. From an adverse events perspective, grade 3 or higher adverse events were uncommon in both treatment groups and very rarely treatment related. Grade 1 through 4 more common. If you look at between the two groups, common in both, usually mild. If you exclude injection site reactions, you can see that the long-acting rilpivirine still similar oral. Leading to discontinuation, though, of long-acting cab, 1. So although injection site reactions were not rare, it was extremely rare for people to discontinue therapy as a result of it. The breakdown on the injection site reactions was grade 1s about 63%, grade 2s 10%, grade 3s less than 1%. And again, leading to treatment discontinuation in just that one individual. And if you look at 48 weeks and you look at patient satisfaction, in general, it was increased for long-acting cab versus oral. So in my view, this data looks extremely similar to the registrational trials done for this regimen in the Western world, and is really supportive of the fact that this kind of strategy can be rolled out in other environments, including with this more public health type strategy where you do less testing. There was one other study of long-acting capryl-piperine in suppressed people. And again, a lot of what we saw at this meeting was looking at the ability to use this established regimen in different populations than have been used before. So that one was looking at in resource-limited settings. This is looking at in adolescents between 12 and 18 years of age. And again, virologically suppressed, single-arm, open-label study. They had oral cabotegravir piperine once a day, and then they got switched to long-acting capryl-piperine intramuscular every 8 weeks. And the primary outcome was safety through week 48, and secondary outcome was virologic suppression. These are the baseline characteristics. About half were female. The majority, as you might expect in this age group, had vertical HIV transmission, and the median BMIs were relatively modest at 20. So from an efficacy perspective, at week 24, over 96% had viral loads that remained undetectable, with no cases of confirmed virologic failure. The safety, at least one injection site reaction in about a third, most resolving within 7 days, and 2 had grade 3 injection site abscesses. Both continued on therapy. And at least grade 3 adverse events, not injection site reactions, in about 11%, and no discontinuations due to adverse events. And this is looking at the pattern of the injection site reaction, again, very similar to what we had seen in adults, where most people, the reaction was the worst at the beginning and most common at the beginning, and then over time, it tended to be more mild and to resolve quickly. So again, really well tolerated and highly effective, at least through 24 weeks in an adolescent population. So what did we learn from CARE and IMPACT and the IMPACT 2017 MOCA trial? Well, we learned that long-acting capryl-piperine every 8 weeks was highly effective in this public health approach in resource-limited settings and has the potential for expanded use in these places. Potential for less frequent lab monitoring, even here in the Western world, highly effective in subtype A1 virus. So while all of that original data talked about subtype A1/A6 being a risk factor, it's pretty clear that's not true for A1. And it really is exclusively subtype A6 that may be associated with increased risk of virologic failure. I also think that the CARE study raised serious questions regarding the utility of proviral DNA resistance testing in suppressed patients. Remember, 15% or so had resistance to rilpivirine or cabotegravir, and despite that, almost everybody maintained virologic suppression. And I still think we really don't know exactly how to interpret data from proviral sequencing in clinical practice. And in fact, it really has never been formally looked at in any setting prospectively for its clinical utility. And then finally, long-acting capryl-piperine was well tolerated and effective, at least for 24 weeks in adolescents living with HIV. Now, let's talk about another special population in which therapy is important to consider. And this is related to tuberculosis. And I couldn't resist including this because even I, in my setting, see people with tuberculosis, and obviously it's a bigger issue in resource-limited settings where TB is endemic. And we always struggle a little bit with the rifampicin drug-drug interactions. And as you're all aware, if you can use integrase inhibitor, the current recommendation as far as preferred option is to use dolutegravir twice a day, and that appears to effectively, at least from a PK and some clinical data perspective, maintain suppression in the setting of rifampin. What this study wanted to do was look and see whether you could get away with bictegravir FTC TAF twice a day, not once a day, to overcome the effect on the PK of bictegravir when you use it with rifampin. So this was a study, a relatively small study with 2-to-1 randomization. About 80 people got the 80 got the BID bictegravir, and about 40 got the dolutegravir twice a day, the so-called standard of care. And here's what they described. You can start with the PK on the right, and you can see the PK with BID dosing and rifampin is not as good as bictegravir once a day without rifampin on the right, but it still maintains levels that should be suppressive. So one would predict, despite an effect of rifampin, that the levels are sufficient to maintain suppression. And then if you look at the results of viral loads on the left-hand panel, you can see that there were very similar response rates. So relatively small study. There were no safety issues that came out. There were no issues or concerns related to twice-a-day bictegravir FTC TAF. And this might be an option for people, especially if you're backed into a corner. Although, again, it's twice a day, as is the case with dolutegravir, which is currently the standard that's often used in this setting. I couldn't help but drag out of a recent publication just to share with all of you a highly relevant study. Was a phase 2b study. In this case, they were asking the question, so this wasn't from CROI, forgive me, it's the only thing I introduced that's not at CROI, but I think it's relevant in the context of the previous study. This looked to see whether you really need BID dolutegravir dosing. So they basically did a 1-to-1 randomization of people who were on rifampin and either gave them dolutegravir once a day with TDF3TC, or they did the TDF3TC dolutegravir with another dolutegravir in the PM. And they basically looked at the primary outcome and determined that at less than 50 at week 24 with a lower bound, 95% confidence interval of at least 70 would be considered acceptable. And they found that in both groups, exactly 83% had acceptable lower bounds. And there was no INSTI resistance detected, and the levels appeared to be adequate. Now, this is a relatively small study, about 100 people, 50 per arm, and has some other limitations. But as we start to think about strategies we can use, particularly if it's problematic to do the dolutegravir twice a day, this might be another option, dolutegravir once a day, if you're backed into a corner. Now, another issue that comes up in clinical practice, especially in thinking about long-acting cabrylpivirine, is that we do see blips. And while we're used to that with oral therapy, and we feel pretty comfortable monitoring people over time while they're taking their daily therapy to make sure that they don't experience virologic failure, obviously we have somewhat less experience with cabrylpivirine treated in people who are stably suppressed. So this was an analysis from the SOLAR trial, which was a trial that compared every 8-week long-acting cabrylpivirine to standard of care bictegravir FTC TAF. And they did an exploratory analysis looking at blips, standard definition of a single RNA of between 50 and 200, followed by an undetectable or less than 50 at least, versus confirmed virologic failure, 2 consecutive RNAs of over 200. And in this analysis, again, it's a limited analysis looking at this retrospectively in one study. They found that there was a group of people that did receive or did not receive the open label, the oral lead-in, OLI. And then there were people who received, so they did or they did not. And you can see overall, for those who received long-acting cabrylpivirine, the blip rate was 4%, compared to the BF-TAF group, where the blip rate was also 4%. So no difference in the frequency of blips between these two study arms. And they found that for long-acting cabrylpivirine, confirmed virologic failure occurred in 1 person with the oral lead-in, 1 person without the oral lead-in, and no BF-TAFs. And there were no confirmed failures in those who blipped. So those who did fail were not the same people that experienced blips. So I think overall, we can say that in general, on long-acting cabrylpivirine, isolated blips between 50 and 200 are more likely than not going to continue to do well as long as they're getting injections on a regular basis. And these were looking at the participants with blips. Again, the numbers are really small for the virologic non-response group. And you can see that there were some that met this criteria in the cabrylpivirine every 2 months, and there were some in the BF-TAF. But again, no confirmed virologic failures amongst those who experience blips. And I think this is reassuring in our practice when we do see these intermittent low-level viremias that we can continue to watch and monitor closely. Now, the other thing I mentioned earlier in the context of the CARE study is this issue of hepatitis B reactivation. And as we're using more and more long-acting cabrylpivirine, where we're switching people who are often on a tenofovir-based regimen to a regimen that doesn't include a drug with activity against hepatitis B, we're forced to ask the question as to whether our people who have evidence of past hep B infection are at risk for reactivation. And there have been some case reports that you're probably all aware of people who have indeed not had chronic hep B based on surface antigen or DNA or both at the time of the switch, but were just core antibody positive who switched and did indeed experience reactivation. So it's a bit of an unanswered questions, and the guidelines, at least the current guidelines, have not been too helpful yet, although I think they're going to be revised to provide some more guidance for us as this becomes a bigger and bigger problem. And I think the CARE study illustrated how big an issue it is when about 1/3 of the people who were screened were ultimately excluded because they had evidence of anti-hep B core without surface antigen. So this was a study that looked retrospectively at individuals who switched to a regimen that didn't include a hep B drug, either dolutegravir-rilpivirine or long-acting cabotegravir-rilpivirine. Now, there were 7 of them who were so-called lone core positive. So they had anti-hep B core, but no surface antibody and no surface antigen. And then 34 of them had both core and surface antibody. And then they monitored these people for about 7 to 9 months, and they looked for hep B reactivation based on ALT bumps that were then followed by a DNA to confirm that this was indeed reactivation. And what they reported, again, retrospective study, 34 people, there were no reactivations in those who had surface antibody. But there was 1 of the 7, so again, the numbers are very small, who was an isolated anti-core that did indeed experience rebound. And the top figure demonstrates in the orange bar the ALT. So it went quite high, over 2,000, and then the DNA in the bottom. But then the person was started on a tenofovir FTC-based regimen, and their viral load and transaminases all normalized. So what are the implications of past hep B infection and viral blip data that was presented at CROI? Well, for core antibody and surface antibody positive, it would appear that they are at very low risk for HBV rebound when switched. And I think there's other data that's consistent with this. Now, for the lone core, the data sets are smaller and mostly looking at it anecdotally. We got a little bit of additional data, and I think what we can conclude is that those who are core antibody but surface antibody negative, these are all surface antigen negative people, are at relatively low risk for rebound, but they are at some risk. How we incorporate that into our practice, whether that means that we can do the switch and monitor them closely for transaminase elevation or hep B DNA elevation, or whether we should avoid it or not, I think we still probably need more data and guidance. Hopefully guidelines will provide us additional guidance as to how to manage these kinds of people. And then finally, from a BLIPS perspective on long-acting cabrylpivirine, no more common than standard 3-drug regimen and rarely associated with virologic failure. In fact, in that study, never associated with viral failure. Now let's move on and talk more about long-acting cabrylpivirine, again in different populations. And this was the Latitude study. This was ACTG 5359 that said, well, we have really good data of long-acting cabrylpivirine in people who are very adherent with their oral therapy and enthusiastic about going on long-acting treatment. So with that in mind, we recognize that we have people who are not fully adherent and are challenged with taking oral therapy, but do not have resistance to cabotegravir or rilpivirine. And the question this study tried to address is to whether we could then take these challenged patients and incentivize them to get to undetectable, because we know that's where all of the data exists for long-acting cabrylpivirine is switching suppressed people. So the goal was, can we incentivize these people to get them to undetectable and then safely switch them to long-acting cabergoline. And while one's initial reaction might be, well, of course, once they're undetectable, they're like everybody else, but they're not. There are people who have difficulties engaging in their medication and their care at times. And we do need people on long-acting cabergoline to come back on a regular basis to get their injections. And we know that they're at very high risk if they miss an injection for selecting for integrase or NNRTI-based resistance. So this was a really important phase 3 trial. And what they did was they randomized people who were not suppressed, but motivated for this strategy. They tried to incentivize them with conditional economic incentives, where they would give them money to meet certain targets like viral load suppression. And those who were able to get suppressed would then enter step 2, where they'd be randomized 1-to-1 to receive long-acting cabergoline every 4 weeks with the optional oral lead-in, or continue on their standard therapy, with the idea that then in about a year, they would cross over to long-acting cabergoline. The primary outcome was regimen failure, confirmed viral failure, or treatment discontinuation in step 2. Very challenging study to enroll, as you might imagine, because these are difficult patients, but they are the patients who need our help the most. So it was really important to see, one, whether we could get people to step 2, and 2, whether we could safely keep them on step 2 without them missing doses and experiencing rebound. Some interesting observations that I just wanted to highlight, particularly at baseline in step 2, is that while in order to be randomized in step 2, you had to have undetectable viral load, there were a substantial number that then came in to get that first dose who were actually viremic. In fact, 17% who were assigned to long-acting cabergoline had viremia at the time they actually received the injection. And here is the data that was presented. So this was presentation based upon an interim efficacy review by the Data Safety Monitoring Board. It was a regularly scheduled interim review. And as a result of this review, the Data Safety Monitoring Board said that they have demonstrated efficacy and that the study should be stopped, and those who are on standard of care should be offered long-acting cabotegravir. And what they did was to define a clinically relevant difference. They used this nominal 98.75% confidence interval, with the idea that if somebody demonstrated a difference with this high confidence interval, that it would be considered efficacious and justify premature stopping of the study. And while it didn't quite make that for the primary outcome, there was clearly still a difference. If you look at regimen failure, that was 28 versus 47. But it clearly met this stopping rule for these secondary outcomes of virologic failure, 6 versus 28, a difference of 18.2%, and treatment-related failure, again, 9 versus 29. And it was a result of this analysis that the DSMB recommended the study be stopped, and the team had the opportunity to get this abstract submitted in time to be included in a late breaker presentation. Again, just showing the data from the interim efficacy review. So we're going to be learning a lot more about the results from this study in the future, as the team has the opportunity to do the complete analysis. As far as the timing of long-acting cabergoline injections, remember, a really important concern in this study was, would these challenged patients that have so much difficulty taking medication come in and get their on-time injections? And now it's a study, and that's a little different than the real world, but 93% had on-time injections, so incredibly high, and reassuring if we think about this strategy in clinical practice that we can do this. Confirmed virologic failure in step 2 occurred in 6 versus 28. 2 in each of these arms had new resistance-associated mutations. And then the safety perspective, injection site reactions, as you would predict based on all the previous experience, were not uncommon, but grade 3 or 4 injection site reactions were at about 2%. So that's the Latitude study, looking at people who were struggling to get to undetectable, incentivized to do so, and once undetectable, switched. This is the Ward 86 experience, and we'd heard about this population before. This was an experience where they took people who were at high risk for virologic failure, and in Ward 86, in a single environment where they have wraparound services and they have a lot of experience in working with people who have housing insecurity and who are homeless. And they decided that these are people who, despite all of the efforts, those who were viremic were unable to get them undetectable, many of whom were at very high risk for disease progression and even death, and that out of desperation, offering them long-acting therapy may be justified. Now, because these are high-risk individuals, they decided they were going to put them on every 4-week dosing initially, not every 8-week. And when it was all said and done, they had previously presented the data on a little less than 60 people who are viremic and published it in the Annals of Internal Medicine, showing high rates of virologic suppression, but it was with variable durations of follow-up. What they presented here were 59 individuals who were viremic, who had about 48 to 52, 56 weeks of follow-up. So they all had more extended follow-up. And again, they were all started on every 4-week dosing, but had the option over time, if they were doing well, to consider switching to every 8 weeks. And the primary outcome that they looked at from this retrospective study was viral loads of less than 50 on long-acting capryl-pivirine, with persistent use of this regimen. Again, looking at viral loads at around 48 weeks of follow-up. The baseline characteristics, mostly men, mostly from communities of color, over 50% unstable housing or unhoused, and about 60% using stimulants. Half of them had CD4s less than 200, consistent with the fact that these were people who really were at risk for disease progression. And some of them had very high viral loads, but 85% was over 1,000. So these weren't people who were just hovering at the low viral load range who needed a little help. So here was the efficacy comparing long-acting capryl-pivirine with, or not comparing, but looking at that population, 48 to 59, 81%. And your first reaction looking at this data as well, that's great for a population that was not undetectable despite every effort for orals, but nothing close to what we see in our other long-acting capryl-pivirine studies with suppressed people. But importantly, a substantial number of the 11 people that didn't meet this endpoint didn't fail. So for example, if you see in the table, 5 discontinued long-acting capryl-pivirine and resumed oral therapy. So they didn't experience failure. And when it was all said and done, 55 of the 59 were suppressed, not all of them remaining on long-acting capryl-pivirine, but did achieve suppression. And overall, there were 3 patients who experienced virologic failure. 2 resuppressed on standard therapy, and patient 3 self-discontinued capryl-pivirine and didn't resume oral therapy. So again, can't emphasize enough, this is a single site that has unique experience and resources in addressing some of the needs of this high-risk population, but at least demonstrated in principle that if you can get people engaged and get them on their regular treatment, even those who are having so much trouble with oral therapy, that you can achieve virologic suppression. And I think it's important to emphasize the fact that this is a unique individual population. The other thing that I think is really important to recognize is that, again, it was every 4 weeks, not every 8 weeks at the beginning. And also, you know, we don't have any data with an INSTI and an RTI-based regimen in viremic patients. So this was really going out there and not something that we would ever do, I think, in clinical practice, where we would take a novel regimen never used in a population before and just do it. But again, this emphasizes the fact that this was done out of desperation. And as a result of that desperation, a bunch of people were helped. And we now have some data from this and a few other observational studies that perhaps this is a viable option for consideration. Now, one other viable option for consideration in high-risk individuals that was described at this meeting was a case series from 4 US clinics where people received long-acting cabotegravir plus or minus rilpivirine with long-acting subcutaneous lenacapavir given every 6 months. So this is off-label use, just as the other long-acting cabotegravir in viremic patients is clearly off-label use, meaning not FDA approved, in patients with poor adherence with oral therapy. So you might say, well, why didn't they just use long-acting cabotegravir like the Ward 86 experience? Well, the most common reason was because they had underlying resistance to either NNRTIs or integrase inhibitors. So they were desperate for another long-acting option that might help out viremic patients. So again, small observational data from 4 centers. And if you look at baseline, about half of the people had virologic suppression. That means just a little over half of the people were viremic at the time they started this regimen, and 94% ended up suppressed. So all but 2 of the 34 individuals did ultimately suppress during the course of follow-up on this regimen. So very limited data, off-label use. All of this off-label use drug may be problematic when one tries to access this in clinical practice, but at least we're getting to see some experience of using these kinds of long-acting strategies in extremely high-risk patients who really need help. Now, interestingly, right before the meeting, the IAS-USA published in JAMA new addended recommendations to try to take into account some of this new data and how it might apply in clinical practice to those people who are truly struggling. So this was titled Updated Treatment Recommendations on Use of Cabotegravir in People with HIV from IAS-USA. And the topic was specifically on those who were viremic. And what they concluded was that, and what they recommended is that when supported by intensive follow-up and case management services, injectable cabotegravir may be considered for people viremic who meet the below criteria and when no other treatment options are effective due to the patient's persistent inability to take oral therapy. So a very specific population. And these individuals who are unable to take oral despite extensive efforts, so this is not a treatment of first resort. This is only after everything else that can be done has been done without success. Those who have high risk for progression. So again, there are risks associated with this, including resistance, which could limit treatment options in the future. So they're really saying these should be for the people who are at the highest risk for progression. So all efforts have failed. They're at high risk for bad outcome if you don't do something. And then importantly, they have to have susceptibility to cabotegravir and rilpivirine. So again, a very select population. These are the only guidelines that this currently exists, but I'm sure will be looked at in other guidelines for this very unique population. So take-home messages from long-acting regimens in viremic patients. I can't emphasize enough that the data is extremely limited, not approaching that which we would normally needed to recommend any novel regimen in clinical practice. The currently available long-acting are only approved for suppressed patients or lenacapavir for multi-drug resistant virus. So this is all off-label use. For those viremic without resistance, every effort should be made to support them in achieving viral suppression on oral therapy prior to switch. I think the latitude approach should be the default approach for these people. But then perhaps for those in which you can't achieve that goal, and they're at high risk for progression, consideration can be given, if the drugs are available, to manage them with long-acting cabotegravir with close follow-up and continued intense efforts to support adherence and deal with things like substance use and other social and behavioral determinants. So let's talk about new agents. Obviously, these aren't going to apply immediately, but it's good to know what's on the horizon. First one was described in this study called Artistry. This is a new regimen, not new drugs, but existing drugs in a different way. And what they wanted to do was to see whether they could use daily oral lenacapavir. So it's only approved for subcutaneous use in multi-drug resistant patients, but there is an oral form with the longest half-life with daily bictegravir Now, remember, bictegravir doesn't exist either, and that we can't prescribe bictegravir except with TAF-FTC. So neither of these drugs are clinically available. But the goal was to see, can we use a very simple, what would be a small pill in people who are otherwise on a more complicated regimen that perhaps would benefit from a new drug in a new class, capsid, with bictegravir. So it took people who are virologically suppressed, and they described them all being on a complex antiretroviral regimen, which basically meant that they couldn't be on a single tablet regimen. Small study, and then they randomized them to bictegravir 75 milligrams, not 50, with lenacapavir at 25 or 50 as an oral agent versus continuing standard of care. And you can see virologic suppression at 24 weeks was maintained at very high levels. Again, the number of patients is small, generally well tolerated. And the complex regimens were mostly boosted PIs plus dolutegravir plus other drugs. Now, these people all had presumably full susceptibility to the integrase inhibitor, and some might argue that if their only issue were that they had some nuke resistance or something, it may be that these people could be managed with a simple bictegravir TAF-FTC-based regimen based on what we now know about a fully susceptible second-generation integrase, even with nukes with underlying resistance. But again, a novel regimen that is moving forward into phase 3 trials based on this data. This is another novel regimen, but allows for the potential opportunity of something very different for our patients, and that's once weekly oral therapy. So this was islatravir plus lenacapavir. Again, lenacapavir orally has a long half-life and can be given once a week, and islatravir has a long half-life, can be given once a week. So this is the nucleoside reverse transcriptase translocation inhibitor that's been in development for quite a while. Many of you may remember islatravir development was stalled because of a problem with it reducing lymphocytes and CD4 cells. They ultimately found out that this was dose dependent and that you could use a lower dose, and they're moving it forward for first-line therapy and in suppressed people for daily therapy at a dose of 0.25 milligrams. This was weekly, using it at a dose of 2 milligrams once a week, which was predicted that it would not impact lymphocytes, along with lenacapavir 300 milligrams orally. So stably suppressed people, T cell count of over 350, relatively small study of about 100 people, compared it to the BF-TAF that they were already on, and looked for continued viral suppression and tolerability. And you can see virologic suppression was maintained at extremely high rates. And from a safety perspective, not surprising, we saw a little bit more in the way of adverse events with the new regimen versus continuing an old regimen, but it was mostly things like dry mouth and nausea. Grade 3 adverse events were also relatively rare. And when they looked at lymphocytes, there was no significant difference in the change in lymphocytes between those who stayed on BF-TAF versus switched. If anything, the absolute numbers were trending towards a greater decrease in the BF-TAF. So it doesn't look like the lymphocyte issue will be a problem. So obviously we need bigger studies, phase 3 data, but this may be the next big advance for our patients in clinical practice, the possibility of a once weekly oral regimen. We'll see what the data shows. Now, we have other new drugs that were described at the meeting. Again, these are in the distant horizon for the most part. This was a novel non-nucleoside reverse transcriptase inhibitor. I won't go through the details of this figure, but you can see that in general, even people who had resistance to rilpivirine and efavirenz, the blue and the orange, still had susceptibility, many of them, to 5894 in the green. So it's active against some viruses that are efavirenz and rilpivirine resistance. It seems to slowly select for resistant mutations in vitro, so that barrier to resistance may be a little bit higher than other NNRTIs, and is predicted to have low metabolic clearance. Here's a novel INSTI, GS1720. This was a single-dose study looking at the pharmacokinetics, and as was predicted, it has a very long half-life of almost 9.5 days. So it's predicted this could be used infrequently. Here's the viral load data using different doses, and at most of the doses, they saw substantial reduction at the higher doses of greater than 2 logs. So the half-life for this also supports the possibility of once weekly or even less frequent dosing. And this too is going to be looked at with once weekly therapy with lenacapavir. So again, another potential option of a once weekly oral regimen for people who might find that advantageous. But again, the studies are still off in the future. Here's a novel nucleoside reverse transcriptase translocation inhibitor. So a cousin of islatravir. And what was presented at this meeting was mostly the pharmacokinetics, showing it too has a long half-life. The terminal half-life was 9 to 12 days, which would support Q-week or even longer dosing. I think where this they described may have the biggest potential role is in the context of prevention. Islatravir was going to be looked at for PrEP, both as an implant and as an oral regimen, but because of the lymphocyte problem, it's not moving forward in that indication. But this might be another option. And they at least reported that it did not seem to have an impact on lymphocyte count. Here's the virologic data. Some of the results are a little bit mixed, but in general, with the higher doses, they did indeed see a significant reduction in viral load. So what are the clinical advances with new antiretrovirals, small molecule antiretrovirals, major advances, particularly moving forward, I think, with once weekly oral therapy, both with lenacapavir, with either the islatravir or a novel INSTI. New drugs may simplify regimens, perhaps novel 2-drug regimens that have advantages for select patients and may be active against resistant virus. Now, finally, I'm going to close with another sort of group of new potential antivirals, and these are the monoclonal antibodies. There were several studies looking at this in the context as an antiviral. As you know, there's a lot of interest in monoclonal antibodies, not just for their antiviral activity, but as well as their potential role in cure research. This is focusing on from an antiviral perspective, and again, very early data. So this was the study called the Banner study, which used a monoclonal antibody, and it simply looked at, in this open label study, what the intrinsic activity was. And there was part 1 where they used 1 of 2 doses, and then part 2 where they used several doses, IV, and they also had a subcutaneous 700 milligram dose. And they had various endpoints for virologic decline after a single infusion. They did not pre-screen the viruses for susceptibility to this monoclonal antibody in real time. And this has been one of the big issues, in that despite the fact that these are all broadly neutralizing monoclonals, they aren't active against all of the primary isolates circulating in the community. And you can see that for the setting where there was activity, and it varied a bit by dose and probably by population, they did see upwards of a 1.5 log reduction in viral load with a monoclonal antibody, either given IV or subcutaneously. This was another study. This was an ACTG study 5357, a phase 2 study looking at this specific modified VRC07 523 LS, where the LS prolongs the half-life of the drug, making it so that it could potentially be used as infrequently as every 6 months. And here they were using it with cabotegravir, another long-acting agent that we know is effective, at least when used in combination with rilpivirine. So the VRC07 binds CD4, has this long half-life, and this was a phase 2 study. So it enrolled people who were virologically suppressed, CD4s of over 350, no history of virologic failure, and they were all screened for susceptibility, meaning they looked at the virus that was present in the PBMCs, and they looked at susceptibility of the viruses. And they had various criteria they used. And one of the big issues that continues to come up is that, one, even if you screen, do we really know what specific criteria to use to define who's likely to have activity or not? So they had step 1, 4 to 5 week oral cab lead-in plus 2 nukes. And if they remained suppressed, then they were switched to long-acting cabotegravir with the infusion IV of this new monoclonal antibody, the primary outcome was safety, as well as they looked at efficacy. And here was the breakdown. I emphasize in the consort figure that there were 36 people who did not meet the predicted IC50 criteria. So we do lose people when we screen them because the monoclonal antibodies are not fully active. And ultimately in step 2, there were 71 who received the combination of the long-acting monoclonal with CAB. And then a bunch with pretty good follow-up. And these are the results. Forgive me for this being so small. From a safety perspective, mostly it was grade 1 infusion reactions. There were a few grade 3 events, mostly the kinds of things that you might expect, like chills, feeling unwell, non-specific things like aching and fatigue. And from the virologic failure perspective, there were very few. The majority of people did indeed maintain virologic suppression on this novel, long-acting, 2-drug, if you will, regimen. There were 5 virologic failures, 2 resuppressed on long-acting regimen, and 1 had low-level viremia after switching to oral standard of care. And there were 2 that were reported to have had this viral failure within 2 weeks of an Mpox vaccine, and the possibility that this may have stimulated a little viral replication that might have been self-limiting. So again, small study, proof of principle that in select settings, a long-acting monoclonal antibody could be another option as an antiviral agent. And finally, there was another study. This was a follow-up study looking at long-acting lenacapavir sub-Q with BNAb. So this was a proof of principle to say, gee, can we ever get to that every 6-month therapy that I think the majority of people thought could be most impactful in clinical practice if we could get there. So this is using the lenacapavir that we all know well. And then it was using 2 monoclonal antibodies, one binded CD4, so-called TAB, the other V3 glycan. Both of them have long half-lives. They have that modified LS that allows them to be given on an every 6-month basis. When they looked for susceptibility to both was relatively uncommon in the community. A little bit higher, you saw susceptibility to one or the other. And you can see in these orange boxes, to the left, those who were susceptible to ZAB, to the right lower quadrant, those who were susceptible to TAB, the right upper quadrant were susceptible to both, and then the left lower quadrant wasn't susceptible to either. So there was a phase 1b study looking at single dose of people that were susceptible to both, so a relatively rare group, and a proof of principle that is a single dose of every 6-month lenacapavir dosing with these infusions of TAB and ZAB that they were able to maintain virologic suppression after 6 months. So this study looked at patients who were not susceptible to one or the other. The question was, how effective will lenacapavir be if there's one active monoclonal? And they'd had 2 groups, one that got TAB 30 milligrams per kilogram with ZAB either 10 or another group with 30 to look at the different doses. The endpoint was week 26, safety, tolerability, and RNA. And overall, tolerability was very good. And viral suppression occurred in 6 of the 6 on ZAB 30 milligrams and 2 of the 4 on ZAB 10. The only predictor of virologic failure was the dose of ZAB. And you can see there's sort of borderline susceptibility for both of these 2 individuals that failed. So again, proof of principle, early data, that perhaps with the higher dose of ZAB, this could be, if not this, another monoclonal antibody combination with lenacapavir, that 6-month option that everybody thinks would be so helpful. So monoclonal antibodies have potential role as long-acting therapy. The role of susceptibility testing is likely to be important, but more data is going to be needed to explain how we should really ideally use it. And although we didn't talk about this, about BNAbs, they certainly are going to have a continued research in the area of cure strategies. So we've seen a lot. CROI showed a lot of new data demonstrating the safety and efficacy of long-acting CAB in new patient populations where it may be extremely impactful, and that new drugs are likely to open the door to novel regimens and dosing schedules in the not too distant future. So now let's come back to our pre-test questions, and we'll do a post-test. Which of the following is true regarding the data from CARES? That was the long-acting caprylipivirine in Africa. Virologic failure was more common in those with resistance identified by proviral testing. There was no increased risk of virologic failure in those subtype A1. Viral suppression was more common in those on long-acting caprylipivirine than continued oral therapy, and injection site reactions were common and resulted in several participants discontinuing treatment. Go ahead and vote. So we have about 50% said B, 40% said C. So let's see, what is the right answer? Well, B is the right answer. Although more than 50% of the study participants had subtype A1 virus, there was only one virologic failure amongst these individuals. In contrast, viral failure was not more common in those with resistance identified by proviral testing. Viral suppression was similar between study arms, and although injection site reactions were common, only one person discontinued because of it. Post-test question 2, which is true about the Latitude trial? It was not a randomized clinical study. All participants had virologic suppression at the time they started long-acting caprylipivirine. Those given long-acting caprylipivirine had lower rates of virologic and treatment-related failure. And D, in the LA caprylipivirine group, on-time dosing only occurred 70% of the time. Go ahead and vote. Okay, so the majority of you picked C. And that was the correct answer. There was a lower rate of virologic and treatment failure in those randomized to long-acting caprylipivirine, which led to the study being prematurely stopped by the Data Safety Monitoring Board. In contrast, Latitude was a randomized clinical trial, and about 15% of the study participants had detectable RNA at the time the study drug was actually given during that step 2, and dosing was on time more than 90% of the time. So with that, I want to thank all of you for your attention, and we will open it up to question and answer. I'll turn it over to Judy to lead this.
Thank you so much, Eric. That was fantastic. Really, a lot of great information. And actually, while we're on the Latitude study, I do want to clarify, the study wasn't stopped. The study is still ongoing. Randomization was stopped, and all of the participants who were on oral therapy are being offered the long acting. So the study still will continue. And as you said, a lot more data will come from it.
Thank you.
I wanted to clarify that.
Absolutely.
So lots of great questions here. I'm going to kind of try to put them in some bins. A lot around Hep B and caprylipivirine, and really what we should be kind of how to interpret this Hep B data. For those, I guess I would just ask you to just say a few words about how you think we should be screening, and if somebody is core antibody positive, should they be vaccinated?
Okay, great. All really important and great questions. So everybody needs to be screened for hepatitis B, regardless of what therapy they're on, or they're going to start, or if they're not on therapy, they all need to be screened. And you're absolutely right. So those who are antigen positive, they have chronic hepatitis B. I mean, almost certainly, unless it's acute, and they need treatment. They need referral to treatment. For those who are negative for surface antibody and core antibody, they all need to be vaccinated, no doubt. Those are the easy ones. For the people who are just core antibody positive, the current guidelines are to vaccinate them. The overwhelming majority of those people are probably previously infected who had waning surface antibody. And this would verify that by boosting their antibody response. So that they all should get vaccinated. Now, they may or may not respond to it, although many will. And then those who are on therapy with Hep B active drugs and stopping, who still don't have antibodies after being vaccinated, that's the group in question. I don't think there's much doubt surface antibody, core antibody positive people are pretty low risk. I can't say it's zero, but it's probably pretty low. That's really the unique group in question. And I don't know the right answer. My general feeling was that if there's a really compelling reason for them not to be on tenofovir, I'd probably give them a chance, but there'd have to be a compelling reason to justify that risk, even though the risk is probably small. But that's my personal view.
Okay,
What
great.
do you think, Judy? What are you doing?
Yeah, can you, before I comment, can you stop sharing your slides so that we can see your face? And yeah, I think one of the issues is as the considerations for use of long-acting therapy in low resource settings, are really being considered as what the screening strategy should be, because the reality in many places is people aren't getting screened for Hep B. And we saw that core antibody maybe inappropriately made some people ineligible who could have been eligible. And now we know with the new study from the Beehive study of the Heplisav vaccine that it's very effective. And so I do like the strategy of vaccinating people who are isolated core and observing them and allowing them to go on. But so that I think it's an area where we need more data, but certainly will impair the use of this more widely in settings where there's higher levels of background Hep B. So there are also some questions about this resistance testing from the CARES study, the proviral DNA. I mean, I think it is true, as you said, there was no correlation between the presence of resistance and failure. I guess we have to just be careful about what we take to the bank on this. Does that mean, as you alluded to, that we know for sure there's no relationship because if resistance testing maybe had been done using a different platform, we might have gotten a different answer like we did in the other, in the Atlas and Flare studies. So do you think, where do you think we should go from this? I'm worried that people are going to take home the message that, oh, look, there might have been some resistance, but it didn't matter.
Yeah, so I guess there's two really important messages that we don't want to confuse. One of them is somebody who you really believe has failed in the past and is at risk for, or you've documented on plasma virus that they have resistance, that matters. I don't think there's any question about that. The question is for a subset of people with no history of virologic failure, where you don't have any reason to believe they have underlying resistance, is there a role for proviral testing? And I think the CARES study is telling us no. Now, a third group, following your theme on buckets, is what about the person where you don't have definitive data on their treatment history? You don't know for sure they've never experienced virologic failure. Our clinical trials don't accept that kind of nuance. If there's any concern, we generally don't include them. What about in that setting where they may have selected for resistance, you can't prove it, you can't be certain they have it, is there a role for proviral testing? And I don't think we have the answer to that question yet.
I mean, I certainly understand why they chose that test for that setting. I think, it made sense, but I think it raised more questions maybe than it answered. There was a question in here about cabrylpivirine in pregnant women and children. Any data coming? I think there is data coming soon. I don't think the data is here yet, but anything else that you want to say about that?
I don't know about what data there is or will be in children. We obviously have the adolescent data for 12 to 18-year-olds, which is very reassuring. And then the pregnancy, I know that this is being looked at really carefully in the context of the trials, and my understanding is so far it looks pretty good. But I don't know if Judy, if you have any additional insight.
Yeah, I think it's coming, and I think we'll have good PK data from studies that are being done, and so hopefully it'll be able to be moved along. A couple of questions about just concerns about using rilpivirine in people with prior K103N alone. Worry that sometimes when you see one and an RTI mutation, it may be traveling with others, but are you comfortable with using this combination in that setting?
Yeah, no, it's a really good question, and it was put in the right context, and I think that's the issue. I think we have pretty good data, not huge data sets, but we certainly have lots of in vitro data, and then I think we have some clinical data that shows that if somebody has no history of virologic failure but has the K103N, so transmitted resistance, we know from the registrational trials that those people do well. It's then another leap to say, what about people who've experienced virologic failure in the past and have K103N? And that's where you're right. I think the questioner is right in that you really do need to be confident that resistance testing was done fairly early in the course of virologic failure, and a switch happened before there was the opportunity for additional mutations to develop. So you'd have to really be sure that they only have the 103N. And if you can't be sure, based on their treatment history, you probably would not want to use rilpivirine.
Yeah. And then what about the polymorphic 138A? It's a question about that.
Yeah, I'm not aware of that being an issue, but I'm not sure. I would probably go to the Stanford website. One of the things that Bob Schaefer has added on that site, which I found to be extremely helpful, is for all of the integrase resistant mutations, he actually has a footnote now saying with this mutation, it should be considered contraindicated or something like that to use long-acting rilpivirine. So I'm not sure of the answer to that.
Okay, great. In the Latitude study, there were a couple of questions. One about, was it blinded? And it wasn't, it was open label. But what about interventions that were made for unhoused and stable participants? You want to speak about this? I think really sites had basically used local resources to work with participants. The study didn't directly provide housing, but would you want to talk about?
Yeah, I think that's right. I think the main intervention was you're in the context of a study, which always brings additional resources and manpower, I think, to support our patients. And I would say in this study, probably more than ever, because we all knew what a challenge this was going to be. And then the money, the financial incentive, which may or may not have been used by people in different ways. But otherwise, there were no additional resources provided to support these patients above and beyond that.
And then based on the CARE study, question about whether we should consider reducing the frequency of viral load monitoring to every 24 weeks on people on CAB-RIL.
Yeah, I guess my reaction would be I probably am not enthusiastic about doing that yet. They're coming in for these injections anyway, and the cost is not prohibitive in our setting. But I certainly think in settings where the cost is prohibitive, that knowing that these people were successful would be reassuring to do less frequent testing. What are you doing, Judy, or what do you think?
Yeah, I mean, I think the logistics of setting up the injectable therapy in many clinic settings have been challenging. And I know I've been challenged with making sure people actually get labs drawn when they come in for their injections, and have, been really nervous when they missed a lab draw because the order wasn't there. But I think it is something with time we'll probably be able to back off, and especially after people get sort of through the first year and they're coming in on time for their injections. I think we could really extrapolate to doing it less frequently. Okay, we're running out of time here. A great question about whether there's any injectable options in the pipeline that offer treatment for Hep B or coverage. I think that's clearly a gap in the field, and I know there's some work with a longer acting formulation or a nano formulation potentially of a tenofovir derivative. I don't know other thoughts that you have about that, but nothing that's really in clinical testing that I'm aware of.
Nor I, but it is something we need for those people with chronic Hep B.
Yes, definitely. Wow, these were great questions. I'm sorry I didn't get to answer all of them. I do have a couple of closing slides I want to get to, but first I want to thank Eric for a very comprehensive and clear presentation of a lot of data from CROI. So to get your CME credit, you have to complete your evaluation, and those will be emailed out by 5 o'clock Pacific time today. And then also, if you haven't been listened to the podcast, the new podcast series from IAS-USA, I really highly recommend it while you're out for your daily walk. And then the next webinar on ART and STI prevention coming up on April 24th. We have a couple more great ones in the pipeline here. And on implementation science, I think this will be really interesting coming up in May. And then the in-person, IAS-USA still has live in-person courses. The next one is in Atlanta next week, and Chicago in May. And thank you so much for participating and for your great questions. Hope everybody has a terrific day. Bye-bye.